Good morning, good afternoon, good evening, everyone, and welcome to our ERA scientific webinar, How to Prepare a Healthy Endometrium. For those who doesn't know me, my name is Nasser Al-Asmar, and I am a Genomics Academy Scientific Director, part of Vitalife Group, in a Genomics headquarters in Valencia, Spain. First of all, I would like to say hello to all of our guests who are joining us today from Southeast Asia, Japan, Australia, New Zealand, Korea, Singapore, and so on. And also from other latitudes, actually, such as Europe or even the Americas. A warm welcome to everyone, and thank you for joining us today. Today's agenda will start with a short introduction regarding ERA from my side. It shouldn't take more than 10 minutes. After that, we will have a discussion panel with our guest speakers, finishing with a Q&A session where we will take questions from the audience. For this purpose, please write your comments and questions in the Q&A box. And we will try to make as many questions as possible, but don't worry, because if we don't have plenty of time to make all your questions, we will reply you in the next few days, few weeks. So for the sake of time, I don't want to make this longer. So let's start with the introduction. And well, we were saying that this is the session, a webinar about how to prepare a healthy endometrium. Well, we can talk about the preconceptional space, life checkpoints. We do know that for the success of the embryo implantation, we do have different important points, such as the endometrial microbiota, the maternal embryonic crosstalk, these microvesicles, microRNAs secreted by the endometrium that get inside of the embryo and maybe change the transcriptome of that embryo, allowing to implant or not into the endometrium. Also, it's important, as you know, the process of desidualization, but what I'm going to focus today and the whole webinar is going to be about endometrial receptivity. I don't have that much things to say about endometrial receptivity. You all know how it works, and we have been doing research and clinical for more than 10 years. And I just want to address the classic topic that it's supposed to be that every single patient is going to be receptive at the exact time. So being receptive means that the endometrium is ready to receive the embryo and the embryo can implant. And this should be around 5 days of full progesterone or 120 hours after the first intake of progesterone. But we don't know that this is not always like this. And sometimes this window of implantation is displaced. We can see that some patients or most of the patients will be receptive at this certain time, but we will have patients that would be receptive. That means that they will need 1 or 2 days more of progesterone. And other patients that will be post-receptive. That means that they will need 1 or 2 days less of progesterone. We have plenty of papers published. We have 22 positive papers saying that ERA works, either internal, coming from Igenomix, or external. The clinics has their own experience and publish their data, and they are positive regarding the ERA usefulness. But we do know also that we have some negative results, some results that are claiming that ERA is not working even more lately. Probably there's a trend that says, well, ERA is not working. So let me talk just a little bit about the different parts. So I'm going to talk about 2 papers that are in favor of ERA that were published last year. And I would like to comment also why some of the latest publications maybe are not showing benefit of the ERA in their patients. So starting with this study, this was a retrospective study comparing clinical outcomes between personalized embryo transfer guided by the ERA and conventional frozen embryo transfer in recurrent implantation failure. You can see that there's more than 5 as a mean, more than 5 recurrent implantation failures. So if you check the table, we can see that the implantation rate for the frozen embryo transfer group was close by 19%, but in the personalized embryo transfer, it increased up to 41.7%. Pregnancy rate was 39% in the frozen embryo transfer conventional group versus almost 63% in the personalized embryo transfer group, transferring when the ERA says that the patient is receptive. And the clinical pregnancy rate, it was almost 25% in the frozen embryo transfer in the conventional group versus 50% in the personalized embryo transfer group. There's another paper where they were identifying a woman with a narrow window of embryo implantation using the endometrial receptivity analysis. And in this facility, in this clinic, they usually perform the embryo transfer at progesterone plus 6 in all his patients, having around 60% of pregnancy rate. However, they published a subgroup of 24 patients that after several transferences at this progesterone plus 6 didn't get pregnant. These 24 patients had at least 2 failed IVF cycles with a minimum of 3 good prognosis embryos transferred. In total, they transferred 94 embryos, and half of the patients had previous failed transfer with donor oocytes or non-euploid embryos. So this is the flow chart, starting with 24 patients that performed ERA. They had 17 patients with a non-receptive result, and modifying the transfer day according to the ERA result, they've got 13 patients pregnant, and they had 11 babies delivery. So at the end out of these 17 patients with a dysplasia window of implantation, doing the routine embryo transfer, they had an implantation rate of 3.4 and live birth rate of 1.1% versus transfer guided by ERA when they got 50% of implantation rate and 65 almost percent of live birth rate. But again, we do acknowledge that there's some papers lately that are claiming that the ERA it's not working, and some of them are good papers and good clinics behind. So I would like to say like 3 different points why those papers are not showing the clinical benefit for ERA. And the first one is the population analysis. The ERA is indicated in patients with recurrent implantation failure, not for everyone, not for good prognosis patients, where the rest of the factors, such as an embryo factor, for instance, are ruled out, because it is the population, the recurrent implantation failure population, in which there is a greater risk of presenting a clinical relevant displacement. And I'm going to explain you here. You can see the different stage: 2 days pre-receptive, 1 day pre-receptive, receptive, late receptive, and post-receptive. So I want to tell you with this picture that this is not a stage that changes from here to here. This is something that is gradual. You can see in the colors that is nothing that changed from here to here, but is graduated, okay? So if we have an embryo that we transfer in here, even though we are 1 day pre-receptivity stage, probably you transfer it, but when the embryo is gonna get implanted, it's going to be at receptive stage. And this is what happens usually with patients with good prognosis, no recurrent implantation failure patients. Most of them are gonna fit with pro-receptive result in this area. And this is why we don't see benefits for good prognosis patients for everyone, unless they have a recurrent implantation failure, because as you can see here, most of the patients with recurrent implantation failure with 1 day pre-receptive result are going to fit in here. So unless we move 24 hours the dosage of progesterone and the embryo transfer, they are not going to reach probably their receptivity stage. So second thing, it's monitoring of variables to confirm reproducibility of results. In some of those studies, the limit of endogenous progesterone was established in 1.5 nanogram per milliliter or at the doctor's discretion. And in Igenomix, we always say that it's crucial to measure the endogenous progesterone the day before that we start with the first intake of exogenous progesterone. this value has to be under 1 nanogram per milliliter. So if we are not controlling this, we might have different results. And also there were no obvious control over reproducibility in number of hours in the protocol. So again, we need to follow exactly the same thing that we perform for the mock cycle, for the biopsy cycle, at the transfer cycle. And last but not least, it's important to know that probability of pregnancy. With endometrial receptivity analysis, the goal is to increase the probability of pregnancy. So as an example, if we have a patient that it's 1 day pre-receptive because we perform the ERA, we transfer the embryo 24 hours later, accordingly what the recommendation on the ERA report, this patient has higher chances to get pregnant because it's going to be at receptive stage. Meanwhile, if we have the same embryo, same patient, 1 day pre-receptive, but we didn't analyze by ERA and we don't know what's going on, we don't move the transfer to the next day. So more than probable, we are going to have a transfer that is going to fail, a second transfer that is going to fail again, a third transfer that it's going to fail again. But somehow, you know that the morphokinetics of the embryo could be different. Some are slower, some are faster. So maybe we can find, I put as an example, the fourth attempt, but could be at the second one or could be at the seventh one. Then this embryo, whatever the reason, it's slower. So they will try to get implant when it's at the receptive stage. So patient can get pregnant in pre-receptive stage. Yes, of course, even though we don't move the transfer time, but it's going to be harder. They are going to have lower chances. So just to summarize, and the key messages for my brief introduction is that, first of all, super important population analysis. And the main indication, and we will ask to our guest speakers, but our main indication recommendation would be for recurrent implantation failure patients. Second, we have to monitor the variables to confirm reproducibility of results. Crucial, again, measure the endogenous progesterone the day prior to the first intake of exogenous progesterone has to be lower than 1 nanogram per milliliter. And also, whatever we did on the mock cycle, on the biopsy cycle, talking about hours of progesterone, way of administration, and also the dosage of progesterone, we have to replicate at the transfer cycle. And third, the probability of pregnancy. Again, a non-receptive patient has lower chances to get pregnant, but it's not zero. They have lower chances than if we move the timing of the transfer to a receptive stage, but the probability is not zero. So saying that, I would like to welcome our guest speakers, but prior to that, let me introduce them briefly. We have the honor to have today Professor William Ledger. Professor Ledger is head of discipline of Obstetrics and Gynaecology at the Faculty of Medicine at UNSW, Director of Reproductive Medicine and Senior Staff Specialist at the Royal Hospital for Women's, Sydney, and Fertility Specialist at City Fertility in Sydney, Australia. Good afternoon, Professor Ledger. We also have
Good afternoon, everybody.
Good afternoon. It's a pleasure to have you here, Dr. Shinnosuke Komiya. Dr. Komiya is a HORAC IVF grant from Osaka Clinic Director. So thank you for being here, Dr. Komiya. We have pleasure as well to have Professor Chii-Ruey Tzeng. Professor Tzeng is the founder and CEO of Taipei Fertility Center and honorary professor at Taipei Medical University in Taipei, Taiwan. So hello, Professor Tzeng.
Hello.
How are you?
Fine, thank you.
And last but not least, it's my pleasure as well to have Dr. Suresh Nair. Dr. Nair is the medical director of Monash IVF Singapore and medical director of Seed of Life Fertility and Women's Care and Medical Center. So thank you very much for being here, Dr.
Lovely
Nair.
to be here. Thank you.
Thank you to all of you. And I need to explain also to the audience that we are going to have a couple of polls. So first one is going to be, in which patients are you offering ERA? So we are asking this question, and we are offering a few of possible results: patients with 3 or more previous implantation failures, patients with 2 or more previous implantation failures, patients with 1 or more previous implantation failures, first appointment patients and recurrent implantation failure patients. I'm not using ERA so far, or other. Please go ahead and make your decision. Also for you, doctors and professors, please make your choice.
Yeah.
We have 5 seconds left. Don't be shy. As much data we have, better will be the discussion. Okay, so I think that we are ready to read the results. Almost 50% is telling that patients with 3 or more previous implantation failure, almost 30% patients with 2 or more previous implantation failures, 11% patients with 1 or more previous implantation failures. Then first appointment would be 3%. I'm not using ERA, 8%. Other reasons would be 3%. So then I will ask to our panel that please, could you tell us which patients are you offering ERA? I can start with Dr. Komiya.
In Japan, if 2 failed implantation embryo transfer cycle was checked, we recommend the ERA test for a patient.
Okay, thank you. How about you, Professor Ledger? What would be your main indication, or do you have any different indications?
Yeah. So we generally would offer ERA after 2 transfers of good quality embryos, particularly in younger patients, maybe under 40.
Thank you. Professor Tzeng, what would be your main focus patients that would be recommended to offer in the ERA?
Okay, if the patient's age over 40 and she had 1 diploid embryo, I would do immediately, because the window of displacement is associated with advanced maternal age. But if the patient is under 40, I agree with the Professor Ledger's, probably 2 previous repeat implantation failure, to offer do the EI. So depend on the age, over 40 or under 40.
Okay, thank you. Dr. Nair?
I would echo the opinions of both Professor Ledger and Prof. Tzeng, insofar as the age of cutoff as well, but also in my practice, because we don't have PGT-A, we have many women with poor prognosis and low egg counts, and even in the younger population, if it's just the 1 or 2 embryos, I'll put it to the couple and explain to them the virtue of doing the endometrial. And honestly, the vast majority of them, in excess of 98%, would do their own research and come to the conclusion that this is a good intervention that will try to bring them closer to success.
Okay, so I think that we all agree about the recurrent implantation failure indication. Also, for the audience, below or above 2 embryo transfer, we got like almost 80% of the audience that would transfer, would indicated the ERA in those kind of patients. So I think that this one, the easiest one. So maybe we need to move it. But prior to start with the presentations, and I will ask you all, please, to be short for the sake of time, and to arrive on time to the Q&A session, that I think that it's going to be wonderful from the audience. I would like to introduce this paper from Kasahara in 2021, when they were doing the evaluation of pregnancy outcomes of vitrified worm blastocyst transfer before and after endometrial receptivity analysis in identical patients with recurrent implantation failure, 3 or more failures, when they saw differences in between performing and not performing ERA, and also they check the results between those patients with the ERA performed with a displaced window of implantation and with non-displaced window of implantation. And they found a remarkable success rate in the first embryo transfer for the displaced patients, personalized embryo transfer with ERA. And I would like to comment this just to brief introduction for Dr. Komiya, that is going to give us his experience in this kind of patients. So please, Dr. Komiya, if you can share your screen.
Hi, everyone. Today, I will be presenting the results of our study on the clinical efficacy of ERA test in patients with repeated implantation failure. The focus of our study is on the Japanese population, and we will discuss the positive aspects of the ERA test, especially for a Leigh patient. Endometrial receptivity analysis is a diagnostic tool used to determine the optimal window of implantation and for embryo transfer. Advocates of the test argue that it can help improve pregnancy rate by personalized embryo transfer. However, critics questioning is its efficacy and suggests that further research is needed to establish the benefits, particularly in patients with repeated implantation failure. So our protocol is for the Leigh patient. And this is the inclusion and exclusion criteria. Our study included 99 patients with no prior prognosis and at least 2 consecutive implantation failures. And after applying our exclusion criteria, we analyzed data from 91 cases. The exclusion criteria are shown as follows. And there is no chromosomal abnormality cases and no PGT-A cases. And every patient was used blastocyst for embryo transfer. This is the background summary. And the patient demographics include age, BMI, the number of embryo transfers before and after ERA test, and ERA test result, and endometrial thickness on the embryo transfer day. Then this is the extreme examples. We were also, which are defined as those with 10 or more previous embryo transfer failures. These 6 Leigh patient listed has more than 10 previous embryo transfer, 4 of which result in pregnancy in the embryo transfer cycle after ERA test. And 3 became pregnant in the first embryo transfer after ERA test. And I have to talk about why this was happening. And this is the before and after analysis of ERA test. Our analysis cumulative pregnancy before and after ERA test. And of course, prior to ERA test, the pregnancy rate was 0% because of the inclusion criteria. However, after ERA test, the cumulative pregnancy rate increased to between 50 to 70%. And this is the cumulative pregnancy rate increases as the number of ET increases. We might need to consider correlation between pregnancy rate and the number of ET. And it has been reported that the pregnancy rate increases as a patient goes through more embryo transfers. So this cumulative pregnancy rate rising up because of the they are performed as a the embryo transfers after ERA. So I think it's very natural. But however, other studies have shown that the pregnancy rate decreases as the number of failed embryo transfer cycles increases. The group 0, 1, 2, 3 means the patient of the failed ET cases. Group 0 is their first time embryo transfers, and the group 1 means the previous one failed embryo ET cycle, and group 2 means previous 2 failed ET cycles, and group 3 means the previous 3 or more failed in ET cycles. And clinical pregnancy rate and embryo implantation rate will decrease as the number of failed ET cases, ET cycles. So I think the hypothesis, can ERA remove the ERA can remove the cause of RIF? The number of previous failed ETs should not affect the pregnancy rate after ERA, because ERA can change the timing of implantation. So we performed the logistic regression analysis. Whether the number of previous failed transfers affect the pregnancy rate after ERA test. The objective is the cumulative pregnancy, clinical pregnancy, the 0, 1. And the experimentally variables is the maternal age, BMI, and the ET number before and after ERA test, and the result of ERA, and the endometrial thickness on the embryo transfer day. And this is the result. The result of the regression analysis suggests that the negative effect of impact of a previous failed embryo transfer may be cancelled by ERA testing. There, we need more explain. The ET number before ERA means the number of previously failed ET does not affect pregnancy with ERA. The adjusted odds ratio was 1.07 and the p-value was 0.53. And the ET number after ERA, the adjusted odds ratio was 0.92 and the p-value was 0.975. This means the number of previously failed ET does not affect the number of implantation needed to get pregnant after ERA test. And there is no significant differences depend on the cost of ERA. This means the achieved equivalent result to receptive after WOI adjustment. They all performed the embryo transfer on their adjusted WOI on the day of embryo transfer. So the effect of their differences of WOI was corrected, I think. And this is the summary. In conclusion, our study highlights the potential benefits of ERA test in patients with leaf cases. By identifying the optimal window for embryo transfer, ERA may help improve pregnancy rate and overcome the challenges posed by previous failed transfers. However, of course, further research is needed to confirm these findings and explore the full potential of ERA testing in assisted reproductive treatment. So, in our clinic, after ERA test, the first time embryo transfer, so many people, the patient gets pregnant. So, I don't know the details of a mechanism, but the ERA test is very effective, I think. Thank you.
Thank you very much, Dr. Komiya, for your nice presentation and for showing the data, your data. I don't know if any of our speakers wants to make any comment on this data. Professor Ledger?
Just to congratulate you on the study and to say that I particularly like your evidence that you can reverse the impact of repeated implantation failure by using ERA. It shows how you can correct when the embryos are good by addressing the endometrial factor. I think you did that very nicely.
Thank you.
Dr. Komiya, did you publish this study? Because
now we prepare to write the manuscript.
Sounds good, because
Yeah,
I encourage you to write this manuscript. It's a nice nice work and nice data to show to the rest of the physicians and healthcare providers. So thank you very much, and let's move to the next block and complicated patient cases, because usually when a physician asks, oh, Nasser, I don't know how to start using, we indicate recurrent implantation failure, but somehow sometimes there are some doubts. And I always say, okay, so you can go ahead with the most complicated cases that you have several transferred euploid embryos, even a donor, and the patient don't get pregnant, so you can go ahead. And in this case, I would like to ask Professor Leigh to explain and to talk about his experience with this kind of cases. So please, Professor Leigh.
Fine, let me share my screen.
Perfect.
Good. Well, I mean, thank you for giving me the opportunity to explain to you how my group have been using ERA, certainly over the past 4 years. We started before COVID, which tells me how long it's been. So I just thought I'd share with you a difficult case, and this is a real life case of JZ, who presents with recurrent implantation failure. What's happening here? There we go. And she began her fertility journey in 2015 and had undergone 6 stimulated cycles and had created quite a large number of PGT-A tested embryos. And then she went on. She was a lady originally from Taiwan, and she'd had 8 embryo transfers in Taiwan without an ongoing pregnancy. And her obstetric history was merely an early miscarriage many years earlier. So her complexity, she had high-grade pelvic endometriosis. She had small fibroids, but not really affecting the uterine cavity. But one of her features was she's had no less than 5 hysteroscopies and polypectomies for recurrent, quite large but benign polyps, which is not something that occurs very often. And so she moved to Sydney and came to see us at our hospital, and we discussed how this might be addressed. And given that her embryos were already known to be euploid, it seemed sensible to offer her an ERA. And as I'll show you in a moment, we tend to just use the estrogen and then progestogen cycle to allow us to replicate the treatment cycle to the test cycle. And the outcome of the ERA was to do a transfer of a day 5 embryo 1 day later on day 6. Additionally, we often use the same endometrial biopsy to look for natural killer cells. It's something that is popular in this part of Australia, and she had elevated levels of total and activated NK cells. Her partner was normal, had good serum analysis and DNA fragmentation. So the first thing we did with JZ was to introduce goserelin, Zoladex, once a month to induce pituitary suppression and hypoestrogenism. And that meant that the endometrium was quiescent and that polyps did not form. And then after the ERA data, we gave Proginova estrogen and utrogestan progestogen with timing, and she flew to Taiwan for her embryo transfer of one of the remaining 11 euploid embryos. And the first transfer, she had miscarriage, and then we did the ERA cycle again in 2019. She went to Taiwan. She had two day 5 blastocysts transferred on day 6. And in that cycle, she had the natural killer cell suppression with prednisolone, clexane, and there's the result, was her little daughter. And she was absolutely delighted after such a hard journey with many failures and a great deal of money and time expended. And we felt that this was a case where probably the ERA had indeed made the difference. So I just wanted to show you how we use the ERA. So we start with the menstrual period. If the woman has periods, we give 14 days of Proginova 6 milligrams a day as a standard. You can give more if endometrial thickness is suboptimal. We do ultrasound, and we also watch gonadotrophins and progesterone. And then when the endometrium is more than 7 millimeters at day 14, we give exactly 120 hours of utrogestan timed 200 milligrams 3 times a day. Take the endometrial biopsy. For any of you who are not familiar, it's merely a PIPEL type biopsy, does not require anesthesia. And that is transported to Igenomix lab. I give them 3 more days of progestogen just to stretch things out. They stop, they have a withdrawal bleed, and then we recommence Proginova. And by the time we're ready to move to progesterone, we get the data back from Igenomix. They've never let us down. And so in the immediate subsequent cycle, we can arrange for the embryo transfer. We think that the women who really benefit from this, the case I've shown you, recurrent implantation failure, particularly if the embryos are known to be euploid, and just notwithstanding the cost, the only downside is that there is a 1-month delay because you have to use that month to do the test before you can do the transfer. And I just wanted to comment that the literature looking at research into ERA is somewhat negative at the moment. And I put out some studies. There's one from 2021 saying that routine ERA in the first embryo transfer cycle does not improve things, and that ERA in donor cycles does not improve things. And a meta-analysis has now been published quite recently in Fertility Sterility, again saying there's no benefit. But I would argue that's because these studies are looking in the wrong direction, and most women do not have an endometrial problem. And I can prove that to you from this data from SART, which clearly shows that if you have donor egg, i.e. high quality embryo, the uterus is still receptive up to the age of 47. And the chance of live birth with a donor egg embryo is not affected by age in a population. But therefore, it's mostly down to the egg. Here is a picture of a beautiful egg, and this is a picture of a not beautiful egg. The uterus is usually, but not always, the innocent party. But if you transfer these embryos 2, 3, 4 times and no pregnancy, something is going wrong with the egg, rather than the endometrium. And I just wanted to show you this data from our own group, which is using deep radiomic imaging with an AI to look at the differences between eggs under 36 in blue, eggs from women over 36 in green, and also younger women with cancer whose eggs are poor quality. And you can see there is a difference in egg quality between young and old that's quite consistent. So what we're looking for with the ERA is the subgroup of women who have an endometrial receptivity problem. And if you do ERA on everybody, you will not see that. You will lose the wood for the trees. And so we think these are the kind of factors that might alter the time of optimal receptivity. Problems of implantation, endocrine dysfunction in the natural monthly cycle, alteration in microbiome, immunological factors, and you might suspect that maybe the elevated NK cells in our case may have influenced the receptivity window. But also, a lot of women don't seem to have those factors, and yet when you do ERA, the timing of the transfer is altered. And since cases like that in the early days, we are offering ERA to probably about 10% of our patients. And I would suggest to you that with the right patient selection, the benefits are clear, and you end up with pregnancy quicker and not wasting too many euploid, good quality embryos. Thank you very much.
Thank you very much, Professor Leigh, because you addressed a lot of points. First of all, it's always really nice to see how these complicated patients, complicated cases, they are suffering for years of infertility, and at the end, they have their dreams. They had the dreams of a healthy baby at home. But you address different parts that's so important. When you say we do strictly 120 hours, we say that because most of the patients are going to be receptive at that certain time. So right. This is why you should do the first time, and you mentioned it, we do exactly this. Thank you also for sharing all your protocol, and I think that this could help physicians that wants to start doing or are doing in another way, and they are not see that it's working properly. So maybe they can change it to your way. So thank you very much again for this. And thank you for something that we were saying like forever, that there are good studies, good analysis, but at the end of the day, they are looking for another scope. We already published with Dr. Carlos Simon in 2020 the randomized control trial that it took us 5 years with first visit patients, and we didn't find any differences in per intention to treat because they were good prognosis patients. So thank you again for sharing all of this. I don't know if any of the speakers wants to share any complicated patient like several implantation failures, or we can move for the next block. Okay, I'm pretty sure that you all have this kind of complicated patients, but obviously it could be easier that explain with the slides. So thank you very much, Professor Ledger, and well, looking forward your next answers to the questions. Sure. And let us move to the next block, and we do have in here another poll, combining tools to optimize implantation. So we would like to ask you, to the audience and to the professors, doctors, would you recommend combining PGT-A with ERA? You have to choose between recommend ERA with PGT-A, screening embryos, recommended ERA after failed PGT-A cycles, recommended ERA prior to PGT-A, I'm not using PGT-A, or not using ERA. I guess that not using ERA also can fit in there if in your country you are not allowed to perform PGT-A. So I do think that we have 5 seconds left. Okay, let's see what are the results. Good. We have around 30% that would say, I recommend ERA with PGT-A embryos. Good, 30%. 55 almost percent recommend ERA after failed PGT-A cycles. 7% recommended ERA prior to PGT-A. 2% I'm not using, or I'm not allowed to use PGT-A. And 7% I'm not using ERA. Okay, perfect. So talking about this, I think it's about time for Professor Tzeng to talk about his experience combining these tools, PGT-A and ERA. So Professor Tzeng, whenever you want, the floor is yours.
Okay, thank you very much for the invitation. Right now, I would like to share with you how to prepare a healthy endometrium by optimizing the implantation rate in ART by using PGT-A and ERA. The ERA, I think you all know the receptive, pre-receptive, or late receptive. So I don't repeat again. First, I would like to share with you in the last publication, you can see some conflicting results. For example, in the 10 publications, only 3 showing some significant improve of the ERA testing. So you can see the improved pregnancy rate. But the weakness of these 10 publications is they do not screen the euprote embryo. So only one papers, 2018, they only use the euprote embryo transfer. So again, you see when you do the normal euprote embryo, you can see the pregnancy rate increased 45% versus 42%. But the number is small. However, the other 3 publications from Carlos Simon's group, you can see the problem is they don't control the quality of the embryo. So this is why there are some conflicting data. And recently in our institution, we tried to observe the aging. Female's age is very important for the receptibility of the endometrium. For example, 2 years ago, we collect 76 patients. You can see 3 different groups: under 35, 30 to 40, under 45, and over 45. You can see the receptibility of the endometrium is from 75% down to 54%, 42, and the 37% if maternal age over 45. So you can see aging is very, very important because you decrease the receptibility of the endometrium. And then we divided by two groups. You can see under 40, over 40. Again, obviously, you can see the young age, the receptibility is much, much better than over 40 year of age. So this is initial pilot study, and then we have 52 patients do the frozen embryo transfer, and end up with very respectable pregnancy rate. We obtain a 37 patients get pregnant and 71% of pregnancy. As you can see, each group 100%, 79, 62, 80. So ERA do some benefit effect for those patients. And then we collect more patients. 1 year later, we collect 130 patients. Again, the trend, you can see the trend is not changed. You can see the under 35, 50%, 58, down to 44% if the age is between 40, 45, and down to 38%. So the trend always the same. And then we divide a three group, under 40, 40 to 45, and 45 years of age. Also, you can see the displacement of the window goes down from the 47% to 44 and the 38%. So this slide highlights the displacement of window of implantation is associated with advanced female age and presenting higher rate of pre-receptive endometrium. You can see in this group, 38% is pre-receptive. So it's very similar with Carl Jimon early mentioned. If patients all maybe you can transfer 1 day later. And then we look at these three. So three factors very important. One is female age. One is the quality of the embryo, equality or unequality. The third one is ERA. So we look at the ERA only and divide by three groups, under 35, 35 to 39, and over 40. So if the patient is under 35, you can see the pregnancy almost no difference. See, the ongoing pregnancy, implantation, almost not significant difference. And even after 30, between 35 to 39, the pregnancy also identical. So this is why in the last publication, JAMA, I think it's last year, and also last month, from Human Reproduction, they discussed the paper of Dole. They are not significant because their patients are young patients. So if the patient is young, I think the significance, the value, the benefit of the ERA is not so important until patient over 40. You can see for 40, you can see the pregnancy rate ongoing is 25% versus 48%. That is significant, as well as implantation rate and clinical pregnancy rate. Then we look at the importance of the PGT-A with or without. Again, we divide through three groups of patients under 35, no difference. 59, 61, 35 to 39 already show the improvement of pregnancy from 53% versus 37%, significant. Of course, if the patient over 40 is overwhelming because you almost double the pregnancy rate. At the same time, you diminish the miscarriage rate. You can see here 31 versus 3%. Here is 41% versus 13%. So again, the PGT-A is benefit if the patient over 35. Then we combine, the patient combine both together, and we look at the advanced maternal age, okay, above 35, So again, we have 4 groups, or without, or do EI alone, PGT alone, or do both. Again, of course, you can see if you do nothing, and the patient age average 40, 41, 39, 40. Again, you can see the pregnancy rate is very low and combined with, associated with the high miscarriage rate. So if you are do single one, you do single EI or do PGT-A, it seems to be only EI, you get 33% ongoing pregnancy rate, and do PGT-A, you get 45%. So it seems to be PGT-A is a bit better than EI alone. But the most important, for the advanced maternal age, over 40, average 40, you do both, you get very respectable pregnancy rate, 72%. So that is the curve. You can see the clinical pregnancy rate goes up when you do both, again, with ongoing pregnancy rate. And why it's important? Because this is our data in the last 2 years. 2 years, we do 1,800 PGT-S. Again, if the patient over 40, you can see the equality rate is about 15%, and also 7% is low-level mosaicism. So that is altogether only 22% of the embryo is suitable for frozen embryo transfer when maternal age over 40. So the conclusion is the aging is associated with an increased rate of aneuploidy and impaired endometrial receptivity by increased risk of displacement of window of implantation. And the pre-receptive endometrium is increased if women's age over 40. And the personalized frozen embryo transfer after ERA is very important to optimize the pregnancy outcomes. And the PGT-A is valuable for patients over 39 to optimize the FET outcome. But finally, I think combination of the ERA and the PGT-A in women with advanced age illustrate and shows remarkable effects on increasing implantation rate and the decreasing miscarriage rate. Yeah, that is my conclusion. Thank you. And another ERA outcome, I think is only very limited evaluation. So I think we need more studies, because this omic-based molecular test still need more studies. Again, nowadays they are so-called mirror testing, but still no publication. So this part we need more data to evaluate or validation of the results. Thank you very much.
Thank you very much, Professor Tzeng, for the nice data that you share. Again, it's so important that you show us how it works in your facilities, and if possible, combine these kind of tools. We do know that the age of the woman is so relevant for the chromosomal abnormalities. The higher the age of the patient, the higher probability to have chromosomally abnormal embryos. And combining the tools, at the end, we are going to get better results, because in medicine, in biology, it doesn't exist 100%. And so far, we are still far away of the 100% pregnancy and delivery. And with these tools, I think that we are increasing step by step the probability that our patients not only get pregnant, but have a healthy baby at home. So as I mentioned to Dr. Komiya, Professor Tzeng, it would be great if you are not publishing these results, you make a manuscript and you can develop and get data in order to put it there. Okay, so prior to move to the next block, I would like to remember you that you have a box for to make your questions. You don't need to wait until the very end. You can start doing your questions right now. We already received some questions prior to the webinar, and also during this webinar we are receiving questions. But please, again, don't be shy. Make all your questions that would like to know, and we will make possible to answer live in here. And if it's not possible, again, don't worry about that, because we will come back to you by your email in the next days or weeks. So let's move to the next block. And this block, I call it ERA, the Singapore experience. Dr. Nair told me, well, Nasser, I want to be like humble. I don't want to be like, this is the whole Singapore experience. But Dr. Nair, please explain yourself. And thank you very much for being here again.
Thank you, Dr. Pena. Thank you to all of you and all those listening in. Thank you for this honor and privilege. I'm just going to share with you, not so much the Singapore experience, but the experience of Dr. Suresh Nair, why he went into endometrial, and that's why we are new entrants to this area. Let me just put the slides up. So the topic was how to prepare a healthy endometrium. I think we all have our own way of either hormone replacement or stimulated cycle or superovulated cycle. That would be a discussion for another day. But what made me really look into this was the fact that I was getting dismal outcomes in spite of us. Prof. Tzeng had mentioned that in women, particularly when they are 40 and beyond, in spite of having euploid embryos, we are not going to be, in many times, within the WIO. Cryptonics had yielded us an objective definition of the limited time period during which the maternal endometrium is receptive. And the WI is indeed induced by the presence of exogenous and or endogenous progesterone after proper estradiol priming. This window is short, it's 30 to 36 hours. And depending on the patient, these are the ranges in the natural cycle and the HRT cycles. But the fact still remains that 30% of IVF cycles in which embryo transfer is performed blindly, I would say, the WI is displaced and the endometrial embryo synchrony or EE synchrony is not achieved. The application of the endometrial transcriptomics using the endometrial receptivity analysis test, which couples then NGS sequencing technology to a computational predictor to identify the transcriptomic signatures for each endometrial stage, has brought about these phases where we can possibly, by using personalized embryo transfer techniques, synchronize the embryo transfer to each patient's WI. So moving forwards, now, one other factor that really made me consider this also, along with other things that we're trying to do, is you find that those who have healthcare insurance, in spite of having the healthcare insurance to support the second cycle, a lot of them don't actually go on after a very devastating failed treatment. And in countries where government sponsorship supports multiple cycles, one failed cycle leads to a third of the patients discontinuing treatment as well. And discontinuation is 3 times more likely amongst patients without IVF insurance coverage than those who have. And in developing nations, the problem is even manifold. Lack of access to financial support, patients self-pay, may mean even investing their lifetime savings in a single treatment. And all of this underscores the need to improve IVF outcomes for the first time. I've just got a few cases. We were just new beginners to this. And if I made a comparison of my pre-endometrial phase and my post-endometrial phase, I saw a significant increase in my clinical pregnancies, all of the dynamics of the patients remaining quite the same. So these are just a few study cases I want to just share with you. There's a patient, this couple is married for 4 years, trying since 2019, had extensive deeply infiltrating endometriosis, confirmed by MRI and the ultrasound, and severe OAT, and had 4 ICSI cycles done, 9 embryos painstakingly obtained. I don't have PGT-A in our country. except in the government hospitals, and the government is not satisfied that it's robust enough technology, unfortunately, and therefore we have had to work with our Malaysian counterparts or counterparts around the region to help us with that. So in this case, because of the extensive endometriosis, after 2 unsuccessful cycles, she went through robotic excision of the endometriosis, as you can see here, with a lot of adhesion lysis, and we optimized the pelvis, and I did the hysteroscopy as well. We did the first ERA, and I just want to highlight that we were new entrants to this, and so this result was invalid, but the Emma and Alice was normal. We repeated it, we got a receptive ERA, and we went on to embryo transfer, and she is currently 35+6 pregnant, PP major type 4, will need a C-section soon. The other case is one that's been trying since 2016, has had a previous child, went through 6 cycles of stimulation and FETs using her own eggs, but this was unsuccessful. And we hadn't had ERA at that time. We moved on to the egg donor program in recent times. We had performed the ERA and hysteroscopy on the same day, of course, ERA first and then hysteroscopy in a HRT cycle. And these were the results. Emma and Alice were great, and it was in a receptive phase. And one would ask, why would we do it in a egg donor cycle? Presumably, a good prognosis situation may not be the problem with the endometrium, but only the egg. But this is real-world practice. The patient has gone through the arduous journey of repeated failure cycles. Even if you had, in this case, you had 5 good donor egg embryos, he was not at all willing to go through an embryo transfer just to try her luck and see whether it works. He said, "Doc, do the to the limits of your knowledge and experience." I put it to her what the virtue of endometrial was, and the couple said that this is something they wanted, and they did the test. They found that they are quite certain of their receptive phase and have had the embryo transfer, and thankfully they were successful. So it was performed recently, and she is now pregnant. This is another case, 10 years of marriage. The husband is a mosaic turner, and they wanted to use his sperms and her own eggs. She was getting older, and there were no pregnancies. And again, once again, I subscribe to Prof. Cheng's study data that has shown that even in an egg donor cycle, even if it's in older women, the endometrium may not be optimal. There can be asynchrony, and therefore we did PGT-A, had gotten a good number of euploid embryos, and 5 euploid embryos, had done our PGT, had done our endometrial. They also had a great deal of endometriosis and bilateral hydrosalpinges that developed in later years, and we had to go into excise that and do the adhesion lysis, as you can see here, optimizing in every aspect all of potential for pregnancy, and hence one could then rationalize the small increment in cost of using the endometrial to even further optimize one's chances. And thankfully, we knew what was the receptive phase and embryo transfer, and she's 39 weeks and 4 days pregnant now, and would want to have a C-section soon. Thank you. This is just my small experience with the use of endometrial, which I believe has been instrumental in improving my overall success rates with my patients.
Thank you very much, Dr. Nair, for sharing your experience. Again, it's super important that you share your own experience and let everyone know what's going on in your facility with your patients, and also adding another tool that we were commenting before with Professor Tzeng about the using of PGT-A plus ERA, but you are commenting in here the use of ERA plus the microbiome, and to be sure that we have enough quantity of lactobacilli, and then that we avoid to have an infection with a pathogen that can cause implantation failure, but also a miscarriage. So thank you very much to share your cases, to share what you do. And again, as the rest of the speakers, I would encourage you to publish your data, to send abstracts to congresses, because this is wonderful. I mean, something that is done by Igenomix, it's always under the suspicion that with your great results, it's something to show to the rest of the physicians, to the healthcare providers, that if you use properly the tool, then you can get good results. So prior to start the Q&A session, because we are in a good timing, let me just finish with the last slide. And this is a slide that I borrowed from Dr. Carlos Simon, that it's one of my mentors, and showed me about the scientific innovation cases. Because when a new test come to any medical field that I would like to talk about, particularly in our reproductive medicine field, and also with genetics, then at the very beginning, you have a panacea paradise. So this test looks like that is for everyone. You go to the news and it's going to get pregnant every single patient, but you fall down after that to the harmful hell. Looks like that is for nobody. At the end of the day, we have the consolidation period and the reality. And the reality is that if we follow the rules, if we do the proper indication, the ERA is going to work for our patients. Just you show us in your different cases that the ERA for certain indications is helping the patients to get pregnant earlier and not to wasting embryos. So this is all what I would like to finish. And thank you again to all of you. We have plenty of time. We have almost 20 minutes to make you some questions. So let me start with the questions of the audience. I can see that there is a lot of them. So, okay, there's like a couple of 3 questions actually asking about the same. They are asking about natural cycle. So any advice regarding ERA test with natural cycle? Do you always do ERA with HRT cycle? I would aim for natural frozen embryo transfer as a rule, and it is much more difficult to track for biopsy and subsequent frozen embryo transfer. So please, could you tell us if any of you has experience regarding the using natural cycle to perform the ERA? Yeah, Professor Ledger?
Maybe to kick off, yes, we do. I prefer the estrogen and progestogen regulated cycle, because then you have consistency between the testing cycle and the treatment cycle. But not everyone prefers to do that. I have patients who would rather use their own natural cycle. If so, we tend to give an HCG trigger when the estradiol level is good and the endometrial thickness and follicle size is good, because that then defines time 0 for the biopsy. The problem with the totally natural cycle is spotting the peak of the LH surge requires quite frequent blood sampling, and even so there is an error. And as everybody knows, natural cycles are not consistent from 1 month to the next in most women, so you'll always see a natural variation, and so that there becomes an uncertainty. So I think if we're going to all of the trouble of doing this test, we should try and maximize the chances of getting it right. And then when you get an answer from the ERA test, you can tailor the treatment within the E&P cycle. But yes, you can do it with natural cycle if you have to.
You're on mute.
Thank you. Thank you very much, Professor Ledger. Any other experience regarding natural cycles? Or are you performing always HRT? Because as Professor Ledger says, it's easier to follow and to mimic the HRT cycle. So I don't know if you are using also natural, because also there's kind of a trend right now saying that the not freeze-all, but to see natural cycle was better. So far, I think works equal, but makes our life easier to make frozen embryo transfer. But Dr. Nair, do you want to develop a little bit?
I just reiterate what Bill has said, because in the natural cycle, it's a moving target. There's lack of precision, and the entire test the basis of the entire test is truly precision, trying to get your W or I to plus or minus 3 hours or even closer. I just want to add as well, those of us who have done a ERA test on a hormone replaced cycle must remember that this is not translatable to a stimulated cycle or a natural cycle. That's a point that must be brought across, although sometimes I take this information and try and figure out in my mind, but you can't translate it. I don't know what the thoughts are of the other speakers, but one has to make that point. You can't do an ERA and translate it into the number. That means if you know when you're going to give your intramuscular injections of progesterone, let's say in the natural cycle, you might not get it right as well.
Yeah, it's important to address, and thank you, Dr. Nair, because it is true that if you do a natural cycle, you have to do the transfer in a natural cycle. If you do HRT cycle, MOC cycle, then you have to perform frozen embryo transfer with a HRT cycle. So thank you very much for address that. So next question would be related with eating healthy food. And there's questions asking, do you think a diet, eating healthy food, and sports can increase the health of the endometrium? Anyone that just change the diet of the patient that could get any benefit on the healthy of the endometrium? I can see Dr. Ledger says no.
Well, there's a lot of interest about the endometrial microbiome, and that's been mentioned already in this webinar. At the moment, I think there's not too much really solid data that we have to go on. It's less well supported than ERA, but it does look as if having not enough lactobacillus might be not a good thing. And so I do think that lifestyle can promote lactobacillus and having a healthy vaginal, hence a healthy uterine microbiome. But I don't think that's going to have much effect on the receptivity question. And we do tend to blame patients for a lot of things these days, and you can always point the finger and tell them off for not living a healthy lifestyle, and that's the reason you're not pregnant. It creates a lot of guilt and unhappiness amongst people, and the evidence that actually some of these interventions make a difference is not strong.
But I'd just like to add, I mean, in regard to using the utility of the ALICE, I have a suspicion that the whole story about chronic endometritis is not particularly well studied, but I can't help thinking that it is something that I have to address if I go and make such an effort to do the ERA. And it's been shown in the few patients that I have, I don't have enough to give robust statistical support, that having changed the antibiotics and without using too much in the way of antibiotics, we've had successes. I didn't present those cases, the 4 cases that we've had. Now, is this the reason why she eventually got pregnant? Because we changed antibiotics, we had a clean, so to speak, ALICE? I don't know, but I'd like to think that at least we are one step closer to addressing this problem, because I believe this is quite an issue, not only during the implantation, but also with regard to preterm birth. I think infection is not as much appreciated as I think it should be. That's my 2 cents worth about this whole story about chronic endometritis. Hard to diagnose, but nevertheless, maybe we're one step closer.
Thank you, Dr. Nair. Prior to go to the next question, I would like to come back to the natural cycle, and I would like to ask Professor Tzeng about his opinion.
I think the use HRT cycle is easy to monitor, okay? But if the patient can come back clinically regularly, I think natural cycle is the best, because natural cycle, the corpuscle can produce a relaxing and so forth, some growth factors. So I think for implantation for the ERA, I think is better. But you may judge which one is better. And the other thing very important is intense exposure to estrogen during the artificial endometrium preparation may delay the implantation window. Now, especially in the recently, we observed in our patient, if the total dose of the estrogen more than 144 milligram under, I think is better than over 144 milligrams. So high dose of estrogen may delay the desensitization when you give the progesterone. So that's very important issue.
Agree.
And the optimal estrogen level when you give the progesterone is 150 to 250. For more than 350 picogram of per ml of estrogen is detrimental. That's our not published study.
Thank you very much, Professor Tzeng. There's a question on the chat that was answered by Professor Ledger, but I would like to develop a little bit so we have it here live. Yeah. That is a recent RCT of ERA from Doyle et al. Actually demonstrated a lower live birth rate after using ERA personalized embryo transfer, which is quite worrisome. Could you, the panel, please comment on that finding?
Okay, I think the dose published in JAMA last year, and this month, there's a paper from human reproduction also. Mm-hmm. They have some bias of the dose paper. Number one, they are patients very young. So this in average only 35. So in my study, I show you the patient under 35, there was no difference. Even up to 40, there's still no get beneficial effect from ERA. So that is the one point. The second point is they exclude all the repeat implantation failure patient, because that is the beauty of the ERA. If the patient with once, two times repeat implantation, that we can do ERA to see the window or implantation. So that is very, and also the third weak point is they do not count implantation rate. Some patient maybe transfer 1 embryo, the other maybe transfer 2 embryos. So they do not count, they only count the pregnancy rate. So I think this is the major weak point of their studies.
Yeah, Professor Ledger.
Would just to add, because I was talking in the chat, Doyle's published a couple of papers. The one they had in fertility sterility was a retrospective, but at least they were looking at patients with recurrent implantation failure. It was small and underpowered, and there were trends in favor of ERA, both for clinical pregnancy rate and live birth rate. I suspect if they'd had a bigger number, that trend would have become significant. The randomized trial in JAMA, they excluded women with recurrent implantation failure. They deliberately excluded them. And as we've been saying for the last hour and 20 minutes, that is the group that really benefit the most from this test. So I was very disappointed when I saw all the money and effort that had gone into that big multi-center randomized trial, because it really targets the wrong question. And that's a point we've heard from several of our speakers. So I think that we're still waiting for the big RCT on women with RIF properly selected. And I think that's a group we should target.
Absolutely. And I think I would say that I don't have anything to add to here. As far as you already explained why they didn't find any differences in between. Just only add one thing more, that in this paper, they say a serum progesterone was under 1 nanogram per milliliter, or at the doctor's discretion, instead to do like under 1 nanogram. So it's another thing that could be biased, but the thing of good prognosis patients, no recurrent implantation failure patients, that could be the target. This is why we think that they didn't get any benefit. And we also observed in our RCT from Dr. Carlos Simon. So thank you for your answers. And Professor Ledger, there's a non-selection study in RIF patients ongoing. So it just started. So hopefully in a year, a couple of years, we will have a proper study on selection telling us RIF patients. So if any one of you wants to participate, please let me know after the after the webinar. That it would be our pleasure. So there's also another question that Dr. Komiya replies at the chat, but I would like to bring it up in order that for all of us, note that talking about question having different results in 1 year. So Dr. Komiya, could you, if we can have different results in 1 year apart or not about ERA, could you explain us your experience?
Yeah, and if the EMA or RS test is performed at the same time as the initial ERA test, and the EMA-RS test results show that endometrial flora is distributed, the ERA test result may change after the endometrial flora is corrected. So if the patient with the not so good endometrial flora, the retest of ERA is needed, I think. Of course,
Okay,
after the corrected the endometrial flora.
Okay, so so far we have studies in 3 years apart in egg donors, and it's supposed not to change the receptivity unless there's major changes such as a surgery, or if there's extremely increase of body mass index that we do know that maybe we can check the transcriptomics. Anyway, we always, when we perform an ERA 1 or 2 years apart, we always ask to contact our lab in order to check, okay, we shouldn't do another one, or maybe it's worth it to make a new one. And also, Dr. Komiya, did you ask the question regarding the laparoscopy? If has to be performed, if you are going to perform a laparoscopy, if you perform first the ERA or not? How do you perform it?
Yeah, the WOI may be affected by strong inflammations because such as in the floras disturbed, or the infections, or the some kind of scratches techniques. So the ERA test with should perform it in a the stable condition.
So you recommend to perform prior to take the ERA, just in case it might change something, Professor Tzeng?
I think probably most important, hysteroscopy, try to rule out some adhesion or some polyps, some kind of chronic endometritis. But laparoscopy has some value, because if the patient with endometriosis, maybe we can use the GnRH 1 month GnRH DPhil 1 month before transfer, because they can remove all the inflammatory peritoneal fluid cytokines. So that is also good for implantation. So that is two reasons: hysteroscopy or laparoscopy.
Thank you, Professor Tzeng. As far as I'm with you, I think that you have to tell us something about a new publication.
Yeah, we are prepared. This we are preparing. In the near, we already prepare a manuscript. We submit very soon. Okay. Because last month when I was in Sydney with Biology, we are meeting in Sydney, and I cross upon the Carl Simon, and I show my data, discuss with Carl Simon, say, oh, that's from different center, because nowadays in US, in European country, they almost say, oh, ER is not good, but it depends on, you must look at 3 major factors: the age, reproductive rate, etc. Not just looking at even the estrogen level, how many doses you gave the patient. So all 4 factors are important. So, and then I think the future prospective randomized double-blind study probably can prove this real value.
Thank you, Dr. Tzeng. So we are arriving almost to the end, and I think that we are having a really nice discussion, but I don't want to finish without to have your last word telling us your key messages for the audience, for the health providers, for other physicians. So please, Dr. Komiya, could you tell us in 1 to 3 minutes your take-home message?
Yeah, especially for the patient with leaf cases, the ERA may be the very powerful benefit treatment to solve the problems. And so many patients, they experience the repeated implantation failures. They are strongly damaged and emotional damaged, and of course they are very difficult to keep embryo transfer. It's needed to embryo transfer. Keeping treatment is needed, but they cannot do because there is no hope to get pregnant without ERA test. So I think ERA is very good and very benefitful for the patient with leaf cases. Thank you.
Thank you very much, Dr. Komiya, because this is something that sometimes we forget, that is the emotional burden, but it's there. So, and it's not easy to measure, but the patients know, and you that are in front of the patients know and feel what is the emotional burden. Dr. Nair, please.
I think in a situation that I find myself in, where we have generally very few embryos, many of my patients have had a history of multiple and successful cycles, or even if they've come to me for the first time, the big fundamental thing is 30% of the time when I do it blind, when if I could use that word, and I have just one or two or few embryos, and sometimes particularly lower if they're gone to PGT-A, I got to get it right the first time. So it's got to do with the circumstances we are in, the emotional impact it makes, the abject sort of misery one goes through when it doesn't work. And then the question, I have to pick up the phone and tell my patient across the other line and on the other side, why this didn't work and what could you have done, even if the data is not tremendously robust, but sufficiently robust, doesn't do any major harm, good test, easy to do, at most, at best, just delays it a month or a couple months, and it brings us closer to success, I would say it's worthwhile. And they have expended huge sums of money to go through cycles to get that one priceless embryo. And if you look at and have them say, oh, it was too expensive, I didn't think that it was necessary to do it. I said, no, I've spent tens of thousands of dollars. What is an ERA to help me get closer to my successful outcome? So it's a discussion that I think all of us should have with our couples, good prognosis, not so good prognosis, present them the data. And I think vast majority of our patients, they're pretty intelligent and they would opt for the ERA.
Thank you very much, Dr. Nair, for your words. Professor Tzeng.
Okay. If the patient over 40, I think the ERA and the PGT-A both are necessary. If the patient age 35 to 40, ERA no need, but PGT-A may be some benefit. If the patient under 35, both not necessary. The other is the optimal estrogen level between 150 and 250 before progesterone administration. I think it can provide an optimal microenvironment for ERA or for frozen embryo transfer.
Thank you very much, Professor Tzeng. And last but not least, Professor Ledger, please, your take-home message.
Thanks, NASA. Firstly, it's been great fun to be part of this, and thank you to your group for arranging it and to our audience for asking great questions. I think I'd finish with two comments. Firstly, that we live in a time of social media and easy access to data from patients. And so we are going to be asked about this test, and I think it's important to stay up to date and to not offer it to everyone, but select the right group of patients. And then nothing is better than personal experience. So I'd encourage those listening to look out for some of their very distressed RIF patients and give this a try. That's what I did 5 years ago. And the reason that I'm speaking to you this evening is repeatedly I've seen with the right patient, it seems to make a beneficial difference. and it takes them out of that very bad place that they're in. So I'm supportive.
Well, so we are 2 minutes above time, but I think that we did a great job. Thank you very much to all of you for being here today, for being that open to share your own protocols, your own experience, your own that data for your colleagues. And thank you, because this is, again, extremely useful for them. And at the end of the day, it's for our patients, because we are working everyone for the best of our patients. So I don't want to finish without pointing out the 3 things that I mentioned regarding those studies. And we were mentioning here one published in JAMA, population study, following the rules, following the protocol. And at the end of the day, a result of a non-receptive doesn't mean 0% chances to get pregnant, but lower chances than having a transfer into a receptive endometrium. I don't know if you are going to be at ESHRE in Copenhagen. Hopefully we can see each other there and have a nice scientific conversation together. So I invite you, and I will message you to join me for a chat. And also thank you for all the audience. I do know that we were almost 200 people or more than 150 people during all the discussions. So thank you very much for the questions again. And also, we will reply those questions that we couldn't answer because the time. Thank you very much again, and have a great day.
Thank you. Thank you.
Bye-bye.
Bye-bye.